Yes, ma'am, you can start now.
Great. Good evening, everyone, and welcome to DTechDialogues. As always, we are here with a very high quality and a star-studded program. We know that we're on the brink of Ramadan, the ninth month, which is believed to be the time when the Holy Quran was sent down from heaven as a guidance for men and women, a declaration of direction, and a means of salvation. There is a lot of fasting, but there's also feasting during the month. And of course, let's understand what it does to our human body. And let's also understand how people with diabetes can cope with it better. Because let's not have diabetes as a limitation to the same, but let's assist our people living with diabetes to actually have a better quality of life and be able to have the freedom to observe fasting as well as handle the little bit of feasting as well with great confidence and with great knowledge. So for that, we have a fantastic webinar planned today. And I take great pleasure in inviting our founders who are here today, Dr. Banshi Sabu sir, Dr. Jyoti Dev sir, Dr. Manoj Chawla, each of them to give us just a quick bite today on Ramadan and DTech as such. And I also extend a very warm welcome to Dr. Ajay Tiwari sir and Ms. Cheryl Salas for sparing their time today to be here with us. Banji sir.
Yes, sir. Thank you, Purvi, for this wonderful initiative of DTech Dialogue as Diabetes Technology Meeting, which was a unique for most of diabetologists in India because this meeting is primarily focusing only on technology. We have multiple diabetes meeting in India, but this meeting is dedicated only for diabetes technology. This DTech initiative will definitely increase a lot of awareness about uses of technology. And as you have very rightly said, in this during Ramadan fasting, how we can use or utilize this technology to improve the care for people with diabetes, and also during fasting, neither they should develop very high or nor low sugar during this fasting period. So definitely technology will help them. And today we have a wonderful panelists, as you have already introduced, Dr. Ajay Tiwari and Sharif, but we have two eminent speakers from Middle East, and Dr. Mohammad Hasnin had one lot of work in field of Ramadan and fasting. He has also created a dedicated group, which is also a part of International Diabetic Federation. Now, I being in part of International Diabetic Federation, I talk to the idea of people that it is not the only Ramadan fasting. There are multiple different type of fasting. We are coming out with diabetes and fasting as a dedicated guideline because Ramadan fasting is again very, I will say in for 30 days, you know that how person is doing fasting. While in other religion, particularly in Hindu, and again in Hindus across the country, different people fast in a very different way. So whether technology can help them also. In Jain fasting, again, it is different. In Buddhist, in Jewish. So diabetes and fasting, very important subject. And technology will definitely help. And I'm sure most of us, me, Manoj, Jyoti, you, Ajay, Cheryl, we have used this technology for our patients, even persons with type 1 diabetes, where they will never think of doing fasting. Now, with the help of latest gadgets, even they are doing fasting. So that's what the advantage of this. And I'm sure today all the delegates, all the participants will learn a lot of things and we will have good interaction. But once again, thank you, Purvi, for inviting me and congratulations for doing this wonderful initiative under diabetes technology. Thank you.
Thank you, sir, for always, giving us the global wings as well. And DTech is particularly obliged to you for that. I think we have gained this ground only with your vision and direction. Dr. Jyoti, sir.
Yeah, once again, Purvi, thank you for inviting me as well. And this is a very, very important topic, and DTech has been organizing this right on time. And this is the right time where the doctors require this. And as Dr. Benshi said, in the last 10 years, we have profound improvements in technologies. And once fasting has been a big challenge in Ramadan in diabetes, but with the advancements in continuous glucose monitoring, now what once has been a contraindication to fasting, now it has probably become an indication. So many people can actually fast. And the big challenge in fasting used to be avoidance of hypoglycemia, which has now become a reality with newer medications with no chances of hypoglycemia and with the newer technologies. Once a doctor, while having a conversation with me, said, Jyotidev, the biggest problem with the doctor during Ramadan is the fear when somebody is asking. It need not be Ramadan fast, it can be any religious fasting because it is a culturally very sensitive topic. How to answer to the question. So that is what DTechDialogues will be answering to the doctors, how to answer to the questions of your patients. And we have a line of very distinguished international and national faculty. And thank you very much for involving me. Thank you.
Thank you, sir, for those very practical words of wisdom. And now I invite Dr. Manoj. Please share your thoughts.
So thank you, Purvi, and great to see everyone in this panel. I think a lot has been said about the importance of the topic. And it's great that we have taken this initiative to facilitate healthier means and the ways to go about for those who desire to fast, and also probably make the best use of nutritional practices as well as technology to aid safe fasting methods. So today is a time that we are using a lot of technology to aid fasting, and hoping to hear the experts express their views on the same topic. So with those few words, I think we move ahead and look forward to listening to the experts and the panel discussion. Thanks for having me here, Purvi.
Manoj,
Fantastic.
We can ask Rakesh also. He joined just.
Yes, Dr. Rakesh has also joined. He's also a co-founder of DTech. And welcome, Rakesh. Very quick thoughts you may share on this webinar.
Thanks, Purvi. I'll not come in between the speakers and the audience. So let's start the next session of DTech Dialogues. Thank you.
Thank you so much for your good wishes. And without much ado, let me introduce our first speaker for today, who's going to tackle the biology underlying fasting as well as feasting during Ramadan. Yes, specifically today, we've decided to go with this particular topic. Yes, fasting is in many religions and many sects, we do all follow fasting, but today this is in particular relation with Ramadan. So without much ado, Dr. Hossam Arafa Ghazi, he's an associate professor of medicine at Mansoura University, Egypt, and the president of the Pan-Arab Society of Interventional Endocrinology and Diabetes Technology, PASID. May we have his talk, please? And I can see Dr. Hassanin has just joined in. Welcome, sir.
Welcome, Dr. Muhammad. Welcome.
Hi, everyone. Sorry, I was on mute. Good to see you all.
Thank you.
Great to see you.
Hello everyone, good evening. I'm Hossam Arafa Ghazi. I'm a professor of medicine at the Center of Diabetes and Endocrinology at Mansoura University in Egypt, and also president of the Pan-Arab Society of Interventional Endocrinology and Diabetes Technology. I'm very happy to join distinguished faculty and chairpersons in my colleagues in DTech group in India. And in the next few minutes, I will talk about the biology underlying fasting and feasting during Ramadan. Before I start, this is my disclosure. I do not have any conflict of interest for this lecture. In the beginning, Ramadan fasting represents a unique and large-scale real-life metabolic intervention. It is practiced by annually millions of Muslims present all over the worldwide. Although there is many types of fasting are reported in different religions and different diet protocol, but Ramadan fasting is very unique. It involves a repetitive and structured cycle of fasting and feasting. This is making it the ideal physiological model to study the metabolic flexibility and the insulin dynamics and the energy homeostasis. For the diabetologist, and most of us are diabetologists, Ramadan should not be just only a lifestyle change. It is a biologically meaningful intervention. It has a specific implication on the glucose metabolism and the insulin sensitivity and also the cardiometabolic parameters. In the beginning, let's talk about Ramadan as a metabolic experiment as a whole. The human metabolism, the God created us that usually we have prolonged fasting and some attacks of eating or feasting. But the human metabolism evolved under condition of alternating food availability and unavailability. This is the old human being. Nowadays, with presence of the old technologies and homes and refrigerators, continuous feeding is a modern phenomenon. This is not the old human being used to have this. And this is in contrast sharply with the human biology design. Ramadan fasting restores this pattern by introducing a daily metabolic oscillation between fasting and feeding state. This oscillation activates adaptive hormonal and cellular pathway will be discussed in the next few minutes that often suppressed by continuous feeding in the normal state or the usual human being. And this is particularly have a special concern and special benefits among the patients with type 2 diabetes and the insulin resistance. When you look as an insulin-centered view, during fasting, there is no glucose, so there will be decline of the circulating insulin as a physiological adaptive mechanism. This is the normal. I'm talking about now the normal, not a pathological problem, not a patient taking insulin. I'm talking the normal human being or the normal adult without any medications. The insulin withdrawal, which will subsequently have some metabolic responses. Decrease the insulin during fasting will reduce the hepatic glucose reduction store, hepatic glycogen stores in the liver within the last 6 to 12 hours. It will suppress the hepatic glucose production and will activate the lipolysis in the adipose tissue. This will increase the free fatty acid in the liver, then will be initiation of some controlled ketogenesis. This importantly, those especially with the patients with the severe insulin resistance will improve the glucotoxicity and the lipotoxicity. And this will subsequently be reflected in a beneficial effect on the insulin resistance and the beta cell dysfunction among patients with type 2 diabetes. This transition between glucose-based metabolism in the most of the year to fat and ketone utilization in the 30 days of Ramadan fasting, this is known as metabolic switch. And this is the hallmark of the metabolic health which is appearing in Ramadan. In metabolically healthy individuals, this switch becomes efficiently. But in type 2 diabetes, this switch is usually delayed or incomplete. All of us know the ominous octet, and those patients with insulin resistance or having imbalance between the insulin and glucagon or the alpha and beta cells usually are characterized by fasting hyperglycemia due to increased hepatic glucose production. This is in a patients with a type 2 diabetes. As I said again, in type 2 diabetes, there is a switch which is often delayed or incomplete to the normal due to insulin resistance and ectopic fat accumulation surrounding the visceral fat. In Ramadan fasting, if it is practiced appropriately under supervision and in a perfectly selected patients, this will retrain the metabolic flexibility and improve the energy utilization again among the patients with type 2 diabetes. Some also hormonal and cellular adaptations happen with fasting. The fasting itself triggers a coordinated hormonal response. As we said, with a decrease of the glucose during fasting, the insulin will decrease, the glucagon will increase, the growth hormone will increase, and there is a physiological hypercortisolism or increase in the cortisol level. Also, at the level of the cells, at the level, particularly in the mitochondria, the fasting is suppressing the mTOR gene, which is present in the mitochondria, and suppressing the signaling and will activate the AMPK pathway. This will increase the autophagy and enhance and improve the mitochondrial efficacy and treat its dysfunction and reduce the oxidative stress and down-regulation the chronic inflammation. So fasting is improving the chronic inflammation and increase the autophagy, and these are supporting the metabolic and cellular health. Also during fasting, there is no calories. After fasting, there is a glucose and there is a lot of calories. If it is a structured and well-practiced diet, this will be accompanied by very good changes. But if it is unpracticed and there is a high glycemic load at the beginning of the iftar or beginning of taking the fluids, this will be reflected by severe postprandial hyperglycemia and insulin surge, which will subsequently lead to endothelial dysfunction and increase the oxidative stress. But if it is practiced by low glycemic index or minimal amount or practiced amount of carbohydrates with a lot of beneficial fat and protein, this will improve and preserve the insulin sensitivity. So again, also, there is some changes in Ramadan, not only the fasting itself and depriving of the calorie, but also the sleep deprivation and the circadian rhythm of the hormones and the sleep, all of this are interrupted. And this is also may suggest that if it is well practiced and sleep and diet and exercise well practiced, this will improve the peripheral insulin sensitivity and the lipid metabolism in selected individuals, which is recommended by the scoring in the DAR guidelines or most of the guidelines. That is the proper selection. If you properly select the patients, if you educate the patients, if you advise them for exercise and planned diet and to take medications properly, if they don't have any risk of fasting, this will be reflected in a good health. So as I mentioned before the DAR guidelines, and it's my pleasure to join Dr. Muhammad Hassan in here, we know, and this is the end of my presentation, I will selected some graphs from the previous DAR guidelines, which summarize my presentation. This is the normal feeding. We usually have breakfast and lunch and dinner, and we have some snacks in between. In Ramadan fasting, we have a prolonged fasting followed by interrupted eating, collecting a lot of calories in certain period, especially in some countries and some seasons in which the summer, we have a long fasting hours. We have a long day and short night and short iftar hours. All of this may be reflected sometimes in some countries by poorer outcome. But fortunately, those days, Ramadan is coming in the Middle East in the winter. We have a balance between the day hours, fasting hours, and the evening or eating hours. This is usually is not too much associated by risk of fasting. Also, as we said here, in Ramadan, usually we take a lot of calories at the beginning of the sunset. Then we have some snacks. Then at the pre-dawn or suhoor, we have some calories. This is in contrast to the other days or out of Ramadan. We have breakfast and lunch and dinners and snacks. Then about 8 hours of sleeping, which is deprived of calories. Also, the condition is not related to calories only, but also to water. With progression of the fasting, the body content of the water is decreasing, reflected this by decrease of the body weight, and with a prolonged fasting, especially in hot climates, especially in summer, especially with the prolonged hours of fasting or prolonged days, this will be reflected by decrease of the body weight and dehydration and in decrease of the blood viscosity. And usually, as the DAR guidelines and most of guidelines, we advise our patients with prolonged fasting and uncontrolled hyperglycemia of the random blood sugar, mostly above 300 milligram. With the dehydration, this is increased the blood viscosity, and this is increase the chance to develop thromboembolic problems. And this is usually our patients ask us it is logic that I break my fasting in hypoglycemia. So why I need to break my fasting if there is a hyperglycemia? For a lot of causes, as the hyperglycemia is usually associated with the thromboembolic events, dehydration, and inflammation. So usually we ask the patients to break their fasting. Also, to summarize, this is the normal physiology feeding in a non-diabetic individual. If you take a glucose, this glucose stimulates the insulin secretion. The insulin secretion will inhibit the gluconeogenesis and will improve the glycogen storage in the muscles. And this is the normal and among the patients with non-diabetes. But the fasting also, this is what's happening in the feeding, and this is what's happening in the fasting. In the fasting, there is no glucose, so the insulin secretion will be minimized. So this will stimulate the gluconeogenesis from the liver and will inhibit the muscle uptake and glycogen storage in the muscle. So, Mr. Chairman, dear colleagues, let me end my presentation by this take-home message. The clinical translation for fasting Ramadan among or for the diabetes specialists, from the diabetology perspectives, Ramadan represents a therapeutic window. Actually, improve the insulin sensitivity, reduce the hepatic glucose output, and optimize the medication and timing of the dosing and proper selection is the key of successful beneficial Ramadan fasting. If the patient is fast without guidance, without guidelines, without any educations, usually the poorer outcome is happening. As the DAR guidelines represent the proper selection and trying as much as we can to shift the patient with type 2 diabetes for medications with no or minimal hypoglycemia, like the recent generation sulfonylurea, GLBs, SGLT2, DPP4 inhibitors, basal, modern insulin. All of this, again, in a proper selected patients with educated patients will convert the Ramadan fasting to be a safe, beneficial metabolic intervention. Thank you again, and happy to join you in any questions if there is present. And thank you again for invitation from my friends in the DTech group, and particularly Dr. Purvi Chawla. Thank you.
Thank you so much, Dr. Ghazi, for being here for DTech Dialogues. Enjoyed that rendition of the biology underlying fasting as well as feasting. You've joined in live, so a quick comment from you, it would be wonderful.
Yes. Hello, everyone. Good morning. Good evening. Sorry. Happy to join always my friends in India. Dr. Jyotidev, happy to see you again. Thank you, Dr. Purvi, for invitation. Always I should, and all of us should convince that Ramadan fasting for majority of patients with type 2 diabetes is a beneficial. The two important things is to understand the biology of fasting and what's happening, and try as much as we can in the lifestyle modifications, the modification of the drugs, nutritional advices for the patients. All of this are converting the type 2 diabetes fasting or the patients with diabetes fasting into beneficial for them. They can lose weight, they can get better control of the blood glucose. Usually the problems and the complications happening either among patients with type 1 diabetes who are insisting to fast, or those with a poorly uncontrolled, non-convenient type 2 diabetes because they are just sensing that they will stop the eating, so there is no need to take any medications. Also, we should insist from we should insist also from Islamic point, like Islam and the DAR guidelines mention this, that if the fasting for type 2 diabetes or even with type 1 diabetes, sometimes those patients who are not recommended to fast and they insist to fast, this is in Islam we said that it's haram, it is not recommended, and by religious base ground, they should not fast, and all of us as a doctors, we insist not to fast. Usually, if they are insisting to fast, the complications is happening. Otherwise, majority of patients with type 2 diabetes can safely fasting Ramadan.
Thank you. Thank you so much for those very cogent comments. And with that, let me welcome an absolute authority in diabetes and Ramadan, Professor Mohammad Hasneen, sir. Uh, very warm welcome to you, and we're very grateful. DTech Dialogues is indeed star-studded today, and I think Sir has had decades of experience with this, not just as an individual, but leading the guidelines world over. And we could not be happier that he has joined us today. So let me formally welcome him and also introduce him to all of our audience. Professor Mohammad Hasneen is a professor of medicine at Mohammed bin Rashid University, Dubai, a senior consultant in endocrinology and diabetes at Dubai Hospital, Dubai, and professor of medicine at Gulf Medical University, UAE. He's also co-founder of Diabetes Diploma MSc courses for Cardiff University in the UK since 2007. He was appointed to the post of consultant in the Department of Endocrinology and Diabetes at UK in 2002, and he's been granted the Faculty of Medicine, Alexandria, Egypt, and he has so much of such a large body of work, publications, particularly the IDF DARG practical guidelines, and the so many awards and publications in the field of diabetes and endocrinology, with and in particular with fasting during Ramadan, that I think it would be a waste of our time if we don't give him the stage right away. So, sir, welcome, and please take stage. I also take this opportunity to welcome Dr. Amit Gupta, our co-founder of DTech. Hi, Amit. Great to see you.
Hello, ma'am. Thank you.
Thank you very
Quick
much for the
word.
very kind introduction. It's really pleasure to be among all the friends from India and Dr. Hussam as well from Egypt. It's a great gathering of minds. So let me share my presentation. Okay, so it was quite enjoyable to see the presentation of Professor Hussam and to prepare the theme for what really is the atmosphere for the fasting and what happens to the body in fasting. But the bottom line for fasting is a personal choice. Of course, we have religious recommendations, and as mentioned, the religion advocates or ask a healthy adult person to fast. So two conditions here, adult and healthy. With diabetes, the problem is who's healthy enough and who's not healthy enough. So I might just being diagnosed with diabetes and I'm just following a diet. And maybe my twin brother is with long history of diabetes on dialysis. We are certainly not the same categories. So here comes the medical recommendations. And technology currently is at the heart of the assessment for Ramadan, not just for the risk assessment, for the education, for the public awareness, for certainly for glucose monitoring and insulin delivery. And you guys as faculty here are very much involved in the technology of these aspects, the glucose monitoring and the insulin delivery. The reality is the vast majority of people, specifically with type 2 diabetes, want to fast. Perhaps in type 1 is very much different. Why do some people in one country, even in type 2 diabetes, 46% fast in one country versus 98%? It's not related to how religious they are. Certainly the same would apply to type 1. What is currently happening is potentially in some countries, the medics as well as the religious authorities agree. If you're on this particular high risk level, period, you don't fast. And while in other countries, people are keen to fast, and perhaps that is the difference between one system and the other. But if I were to look into this epidemiology of fasting from our last two large epidemiological studies, it's very different from what the old guidelines were recommending. The old guidelines were simply recommending that the person who's safe to fast is the well-controlled person with type 2 diabetes with maximum
Hello, Dr.
insulin.
Mohammed. Can you interrupt? Can you change this presenter mode? We are seeing in the presenter mode here.
I see. Okay. Sorry
Yeah.
about that.
Yeah, no problem. Thank you very much. Yeah, now it is perfect. Yeah.
Okay, perfect. Sorry, guys. So what I was saying is that the older version of the guidelines, this is 26, so 10 years ago, the only people we were saying you're moderate or low risk is the well-controlled person with type 2 diabetes who is maximum being on basal insulin. So it's very far from the reality. Now, the reality is when we need to assess a person, we have to think of evidence-based, we have to individualize the care, and of course, it has to be clinically practical and aligning with the religious regulations. And the road to the current scenario has been quite a long road with lots of guidelines and studies. Our first document with the ADA was in 2005. And that was a simple mere consensus because there was hardly any evidence then. But since then, there's been a huge amount of studies. Indeed, since the last guidelines was produced in 2021, till date, there's 272 clinical trials on fasting in people who want to fast Ramadan with diabetes. When we produced our risk calculator in 2021, that was a major breakthrough because instead of having individual opinions with the use of technology on your app, on your electronic medical records, or check online and print it, you would be able to do the assessment wherever you are in the globe for the particular clinical scenario. The validation studies that took part since then were really quite amazing. They were from all over the globe. And indeed, even a meta-analysis that was published last year, few months back, they all confirm the predictive value of the calculator where hypoglycemia and hyperglycemia were low in those who were low, were high in those who were high. But obviously, there is room for improvement. I'm delighted that along with our co-speaker tonight from India, Chehla Sheikh, my very dear friend Bashar Effendi, and my close friend Munir Al Arouj from Kuwait, we have won for this risk calculator. As you can see here, the Diabetes in Ramadan risk calculator, the Sheikh Hamdan Award for Health Innovations. Honestly, I thought this will go for a robotic type of surgery or something of sort. But the committee, which was largely from Switzerland and many other universities, have decided that because of the simplicity and the importance of this that can touch the lives of millions across the globe, they decided to give us the prize. Since then, there's been a large number of emerging evidence that helped us to further modify and purify the risk calculator. These are some of the studies that we just published last month, and many more studies are done by other colleagues elsewhere in the globe. This is the picture of the 59 global author for the latest ADA IDF guidelines that have just been launched. And it includes experts from 5 different continents. South America, you can call it a pan-global document. As I mentioned, only South America we didn't have authors from. But Australia, Canada, US, Europe, Asia, Africa, and of course, Middle East, many colleagues and experts in the field, including the president of IDF, Peter Schwartz, the vice president of the ADA, Nohal Al-Sayed, were co-authors with us. The process took multi-stage conversation and consensus to review the evidence and to look into the validation studies and to assess and re-weight the existing risk factors, and thereafter shared with all the authors to debate and discuss and come with the current calculator. I'm delighted that the current risk calculator is part of the ADA Standards of Care of 2026, as well as the previous one, and indeed it's available on the Dar Academy app. Please download the Dar Academy. It's free, it's non-commercial, and in it you will have the risk calculator. You might think it's a lot of aspects to assess. Trust me, it will take you less than 1 minute to assess the individual in front of you in clinic to come with a decision about fasting. So we go through the points: pregnant or not, type of diabetes, duration of diabetes, the type of therapy that people are on. And obviously here, people could be on multiple of these options. The frequency, the awareness, and the severity of hypoglycemia. The level of glycemic control with the HbA1c, and the level of glucose monitoring, whether they are on CGM, and here recognition of the value of the predictive value and the preventive value of the CGM to prevent problems by giving it minus 0.5 rather than those who are doing it adequately with SMBG just 0. Diabetes-related emergencies, macrovascular problems, microvascular problems, and for the first time, evidence about the number of microvascular complications, 1, 2, 3, or nil, which with evidence we've seen that they have an impact. Consequently, the level of the score will come to be 0 to 3, 3.25 to 6, or over 6, which is considered high. High is high, and we say, don't fast, it's unsafe. Low, we say, we do not know of a problem, it is safe. Moderate, we say, we're uncertain here, and then the person has a choice. Whether they wish to fast, then they need to follow the advice of the expert, or they wish not to fast, they have the right, the religious as well as the scientific right. So one of the important questions, how can technology help safer Ramadan fasting? Certainly technology, and as you can see here, this is the picture of the risk calculator on my hospital electronic medical records. So having the Excel sheet, and trust me, my dear friends, it's very simple. Just put all the aspects on an Excel and give it to your IT guys, and they will be able to do it, so we don't have to have the variation from a doctor to doctor. Of course, with the digital applications of the IDF website or the ADA standards of care, we can log in or even print it. But the issue does not stop with the risk calculation. Me, as a person who might wish to fast, I might insist on fasting even if my risk category is moderate or indeed high. But I would like first to talk about the person who decides not to fast. That person should not be ignored. They should receive education as well. Because if you're living in a Muslim atmosphere, you will be reluctant or shy to eat and drink when other people are fasting. So hence, that person might be at risk of hypoglycemia as much as the person who's fasting. And then at the time of the meal, and as was been presented in the previous presentation, where many people feast at the meal time, they also will be exposed to the hyperglycemia. So safe Ramadan doesn't necessarily means the safety for the person who's fasting only. Now, come the question about, and this was one of the recent studies that we've just recently published. The vast majority of people who decide not to fast have an issue related to complications, multiple insulin, age, or indeed, some of them, they just want to exercise their right because of their health issue of not fasting. But then the more serious issue is for the person who decides to fast. Very important that we provide them with education, and I will touch on that shortly. But we need from this risk calculator to identify the modifiable risk factors. I cannot modify my type of diabetes or the many years of diabetes. I cannot maybe reverse a renal problem, but many other aspects. And today I saw someone with hypo unawareness, and I was talking to him of how can we regain his hypo awareness which will take him from a very high risk to potentially a moderate risk. So identifying the measures or the aspects of modification of risk factors and then trying the trial fast. Finally, we produce the personalized management plan just before Ramadan starts, and that would help. The education really is quite key. We look into the nutritional aspects. Ramadan, unfortunately, has changed from not just the month of fasting, but to the month of feasting for 30 days. The treatment modification, the frequency of monitoring and the type of monitoring, as well as breaking the fast when the person is not well. And it's interesting, in one of our recent publication for type 1, that it was reported that 23 or nearly 24% received the education online and through the apps, which is indeed a very useful tool, because many of you are very busy in your clinic and you haven't got the time to explain all of these points and ins and outs. So perhaps when you advise your patient to log into an app or an online version of education, we indeed have developed the Diabetes in Ramadan patient education app, which is called Dar Safa, which is the abbreviation of Safe Fasting. The information comes here in English, Arabic, Urdu, French, and Turkish. And it includes a patient education program, which is self-learning. And here is the different languages, as I mentioned, by colleagues from these countries who can speak these particular languages. And largely, it also includes the Ramadan nutrition plan, where the person would decide on whether they want to sustain their weight, lose weight, or gain weight. The application would suggest the total number of calories. This is done by colleagues from Harvard, from UK, from Malaysia, and from the Middle East, and will give them a menu of the two main meals in Ramadan and two snacks based on Indian food, Malaysian food, Middle Eastern food, and that really give them, or Gulf food, and give them lots of options. Knowing when to break the fast, because some people, when it comes to the last hour and they develop symptoms of hypo, they are reluctant to stop the fast and having to repeat that day again. Because if you break the fast, you will have to redo that day later in the year. And some are reluctant to break their fast, but it's very important that we explain to them hypo is a hypo and need to be stopped with, of course, ingestion of glucose or a glycemic drink. But certainly, as I mentioned, the education need to reach people with diabetes. We frequently do the healthcare professional education, and definitely the general public and the community leaders and the religious community. If you were to advise your patient about something and then he would or she will go to the mosque and the imam would advise the opposite, then they will listen to the imam and not you. So that harmony certainly is quite important and required. Unfortunately, 60% are the percentage receiving the education, 41% are not. And also the data are saying to us that most of the education is done briefly in clinic by the physician rather than in a systematic approach that covers all the aspects. When we looked in a recent publication just a couple of months ago into type 2 patients either on basal bolus or on twice daily premixed insulin, less than 60% receive the education, although in theory, these are among the highest risks in people with type 2 diabetes. And when we looked into SMBG frequency, it's meant to increase during fasting, but only 13.8% increased the frequency of the blood glucose monitoring. How frequent should I test? Well, obviously that depends on the type of therapy as well as the health of the individual and the social circumstances. So this is the bare minimum for someone during Ramadan fasting. And we say if you're on intensive insulin, it's minimum to be 4 times a day. When should we check? Well, very clearly, the last few hours before sunset are the most vulnerable time, and one of these tests need to be at that time. And of course, the frequency of monitoring goes down according to the type of therapy. Education works, and what we saw in the survey that we've done, that even this brief simple education led to nearly 50% risk reduction of hypoglycemia for people with type 2 diabetes. When we tried to apply what we called optimum care in my hospital in Dubai, of giving people education, providing them with freestyle Libra, adjusting the treatment based on the best advice, we saw quite a significant improvement. So we compared the freestyle Libra data of pre-Ramadan to during Ramadan. Now, the logic would say to me, because of fasting, I would have worse outcome. But the reality was that the HbA1c was better, and all other parameters, as you can see here, did not have any significant worsening. Time in range in target increased. Of course, our patients need to have better control so that we can minimize the above target. Mind you, this was done in 2019, so quite a few years back. And when we applied the same for people with type 1 diabetes, the highest risk group, traditionally in many guidelines, what we saw is that the within target during fasting was hardly different from the time of before, when they were non-fasting, before Ramadan. So clearly, the technology and the education combined together can help many people. So definitely fasting can be a challenge for people with diabetes, not just type 2 diabetes, diabetes in general, as well as healthcare professionals. But a systematic approach using the risk calculator, whether through the electronic medical records or through an app or online or even as a printed piece of paper, and going through the systematic process is really quite important. Identifying the modifiable risk factors can help many people to go through the month safely. Education is essential, whether the person will fast or not. And of course, in all of the above, technology is a fundamental tool for many of these aspects. I have not addressed the role of technology in insulin pumps and in CGMs, which is quite obvious to the mind of so many, and the evidence for this is quite in abundance. Thank you, and I look forward for any questions that come during the meeting.
Thank you so much. This was fantastic to hear, integration of technology for this, for, enhancing our outcomes with during fasting. And I think it was really a wonderful talk, particularly the risk score that has been developed. And I think maybe we all can implement that in our clinics because we do see a large volume of patients. And maybe that's a more objective way of initiating the dialogue with them with respect to fasting.
It's really quite easy. You just download the app on your phone, and at the bottom of the app, sorry, it's not getting a good picture. At the bottom part of the app, you would see the risk calculator. You click it and you start, and it takes you about a minute with the patient in front of you to come to a comprehensive. The patients love it because they feel, rather than a subjective opinion or a quick opinion, that I went through so many aspects with them, that the feedback from my patients, wow, doctor, even you're asking me about my social circumstances.
That's true. So thank you for that, sir. I had one more question. So what about some of the long-term risks associated with fasting during Ramadan? And is there some documentation, particularly of the cardiovascular risk and any association with that?
We unfortunately don't have that because it's really quite difficult to pin that. The one is it's obviously a long-term studies that will need a huge amount of funding and follow-up for people with diabetes, because here you would be trying to assess what happens in 1 month that happens every year, because at the rest of the year, there is so many other confounding factors. And a person who fasted this year maybe is not fasting the following year. Maybe they're on a different type of therapy. But what we know is that the short-term actions, we did one study in our hospital about admissions during the month of Ramadan. And we saw a reduction in in heart failure, but a slight increase in ischemic events. The overall was the same percentage, but perhaps the lack of fluid intake helped people with degrees of heart failure, while it didn't help. But obviously, if we are to apply the risk calculation and advise those with unstable cardiovascular problems or renal impairment, then the fasting would be done by those who are in a much better shape.
Purvi, can I ask a question? Yeah,
Of course,
a
sir.
good question. So there is a question in the WhatsApp to Dr. Muhammad, and this question is from Dr. Ashwin Kumar. And he's asking whether a downloadable slide set is available for patient education from DAR, and which includes some simple pictures, cartoons, so that a half-an-hour education can be given either online or offline. Dr. Muhammad?
We have two apps. One is for healthcare professionals, the DAR Academy, and one for people with diabetes, called the DAR Safa. They're both free. They both have fantastic information. Much of the information is also available on the website, the DAR Alliance website, and they include fantastic amount of information. Honestly, it goes way beyond Ramadan, because you can simply change, say, instead of this meal being the evening meal for at the sunset, this is my evening meal, or my breakfast, or my snack. And the passion of people to fast and to get it right during Ramadan leads to better outcome throughout the year. And that's why we won the Diabetes UK as well as ESD Education Prize, because of the impact over 12 months. So if someone get engaged with us and learn about the impact of their eating and physical activity and treatment, and they monitor a bit more, that level of information will last with them for longer.
Thank you. Thank you very much.
Thank you.
Thank you so much, sir. And we would love if you can hang on a little bit longer for the panel discussion also. We have the next talk coming up is Dr. Shaila Sheikh, and she's also given you her regards. She will be talking on the management of diabetes during Ramadan in the Indian subcontinent and sharing some important practice pearls.
Sure.
Dr. Shaila Sheikh is from Mumbai, a leading consultant and a senior consultant endocrinologist. And not only she's a well-known figure in India, but she's an international global figure, again, working very closely with Sir on the IDF DAR guidelines and representing India as well on these global forums. So, RX Events, I would request you to please play the... Yes.
Hi, everybody. Good evening to each and every one of you out there. At the onset, thanks, Purvi. Thanks for making me a part of this fantastic meeting. It's a pleasure being over here. And of course, it is a great privilege and an honor to be on the same platform as my mentor, my teacher, Dr. Hasnain sir. Honestly, friends, all the research that is being done universally and that has been done in the past decade, the reason why we have changed our management of people with diabetes who are planning to fast in Ramadan, all the credit honestly goes to sir. And I do not exaggerate any word of what I am saying. I believe it. And I mean it when I say that all that I speak today is a result of what sir has taught us over the past few years. And it is, I mean, I would really want to use this platform to, give tribute to this great person who's single-handedly managed to now talk about Ramadan in the ADA guidelines. And that is, believe me, huge. So when I talk about management of diabetes during Ramadan in the Indian subcontinent, whatever I talk is borrowed heavily from what he has taught all of us. Why are we talking specifically about the Indian subcontinent? You and me both at this point of time are actually working overtime simply for the reason that a number of our patients are planning to fast after 15 days. We are actually 15 days away from Ramadan. And when you look at the fact that the people who are going to be fasting this year are going to be fasting for approximately 12 hours, winter is almost ending and it is going to be, of course, not peak summer, but it is going to be reasonably hot. So you are worried about two very, very important factors, both hypoglycemia and dehydration, which we will talk about in some time. But along with that, what you are also very, very worried about is the feasting part of Ramadan, which also needs a lot of education. And in spite of the fact that we've been working very hard from quite some time, trying to incorporate education about the fact that people need to follow up earlier during Ramadan, we at this point of time know that we are increasingly going to see people in the next 15 days who are going to come to you requesting you to manage their medication and hopefully receive guidance as to how they could possibly fast this Ramadan in a very, very peaceful and spiritual way. Now, before I get to Ramadan fasting, a little bit about intermittent fasting per se and religious fasting. I know Ramadan is supposed to be the prototype of dry intermittent fasting, but there are certain subtle differences between the two. I would say more than subtle differences between the two. And the reason I put it that way is because we know when we are having a religious fast, there are fixed timings. There are certain fixed rules about when you fast. For example, in Ramadan, you do not eat or drink anything between dawn to dusk, and that involves intake of any kind of medicine too. That itself increases the risk of dehydration, which is not seen in intermittent fasting. Intermittent fasting, the motivation is more health driven, whereas in a religious fast, the motivation is more spiritual driven. It is more driven as a result, as an intrinsic motivation, as a result of which the person fasts. The risks differ a little because there's no increased risk of hypoglycemia. There could be an increased risk of hyperglycemia. That also is less in intermittent fasting because, as I said, it's a health which motivates you. But yes, there could potentially be an increased risk of hypoglycemia if not done in the right way, but which is much higher when you are doing a religious fast. And that's the reason what we have observed and what all data across the globe shows that there is an increased risk of hypoglycemia definitely due to the long hours of fasting. And in case your medication, especially in the older conventional medication that we're using, which we still continue using in our country, for example, if the dose of SUs or the dose of your conventional insulins is not readjusted, there is definitely an increased risk of hypoglycemia. Fasting does not go without feasting in Ramadan, and we all know that when we look after our patients who are living with Ramadan, not only the patients, feasting I think is an integral part of Ramadan. I'm sure everybody already has their weekends blocked for their iftar parties and all the goodies. But the fact remains that again, if the feasting involves a lot of calories which are going to be calories which are going to be derived mainly from simple carbs, they're going to be derived from glucose, they're going to be derived from sugars, they're going to be derived from a lot of fried food that does result in a lot of hyperglycemia. DK remains an area of concern. And as I said, in our country, dehydration is a very, very important area which we need to educate our patients about. And that is the reason why, friends, you need to stratify your patients. You need to do a risk stratification. Unless you stratify what kind of risk your patient has when this patient fasts, you would not be able to help your patients fast safely. So when you are looking after your patients today, the first thing you would do, or I would say tomorrow, the first thing you would do is stratify what is their risk when they are going to be fasting this Ramadan. And that is what is very, very important during the Ramadan period. I honestly look at the Ramadan period as a window of opportunity. And the reason I say window of opportunity, because I've realized along the road that the one point of time when I manage to make my patients do their complete medical evaluation is during just when they come to us when they want to fast during Ramadan, because the motivation to stay healthy and the motivation to be able to fast all 30 days is enormous. Don't underestimate that motivation. You would be able to help patients undergo that complete annual evaluation that they need to undergo, and often which they do not want to undergo, saying the moment you tell them you need a fundus evaluation, the first reaction is, ma'am, I can see my eyes are fine. Why do I need a fundus evaluation? You ask them to do a microalbumin creat ratio, and the answer is, ma'am, my creat is okay. We did it last year. I think it was quite okay. But you ask them to do it before Ramadan, explaining that, look, we need all these parameters to be in place so that you do not have any problem. And I have a much more compliant patient sitting in front of me. It is also very, very important that when you risk stratify, you evaluate as to what kind of risk your patient has. For example, is this patient having mild risk of fasting where it is absolutely safe? The reason it makes a difference to us where we have cost constraints and where people are spending from their pocket, because if the patient has maybe a mild or very early moderate risk of fasting, the monitoring can possibly reduce. The medication can be readjusted much more easily, and the patient need not undergo that kind of intensive monitoring which they need to undergo if they're at a high risk of fasting and still insist on fasting. And at the end of the day, this is also a period when you can educate not only a patient but a family as to regarding what kind of behavior the person needs to follow so that they not only have a healthy Ramadan, but they're also able to manage their sugars much better throughout the year. We always try, what we have also noticed is that when you have Ramadan focused education, yes, to some extent it is Ramadan focused, there's no questioning that. But along with that positive motivational behavior, which is reinforced pre-Ramadan, especially when you do it in groups, you do it with people together, you do it with families, that goes a long way throughout the year in keeping your patients much more better controlled, because they've already started a pattern of a little healthier living so that they are able to fast safely. And that reiteration, if you continue doing throughout the year, I have personally felt that it does help you in much more positive behavior. As I said, a big thank you, sir, for this. A big thank you for being able to put the risk stratification up there in the ADA guidelines 2026. That is really huge. And it gives me great pleasure to talk about the IDF DAR risk calculator, which is actually just what Sir has been working on over the last few months, and this is for everybody out here. As I said, why are we talking about risk assessment? Because you need to quantify in a very, very simple way what kind of risk your patient has as far as diabetes is concerned. And these are some of the factors which do influence this risk. For example, over here, very, very categorically, pregnancy with any risk of diabetes is a very high risk, and you would not allow your pregnant people living with diabetes to fast. Have that important conversation and request them not to fast. Religion also permits it. Subsequently, you have various criteria over here. For example, type of diabetes, duration of diabetes, type of diabetes treatment, and all this has certain points. If you look at the right side, you have certain points, 1, 2, 3, 4. And these points, when you add up, I'll tell you what it actually means. It's very simple, friends. You can use this. It will be available in an app soon. You can use this simply with paper and pen. You can ask your assistant or your staff to do it outside if you're very busy. And this just needs to be marked. For example, if this patient your patient has come to you, this patient may be on glipizide, glibenclamide, or maybe on gliclazide. It just needs to be marked over there. The person may also be on basal insulin, mark it over there. A person with a diabetes duration of 10 to 20 years, for example, has a marking of 0.5. Whether the person has any hypoglycemia, what is the degree of HbA1c control? Is the person going to monitor the sugars? What kind of hyperglycemic emergencies, macrovascular complications, microvascular complications, labor, and of course, education and fasting hours. I won't get into the details of all this, but what I'm trying to put across over here is that this is a very, very simple risk stratification. Actually, very, very simple, though a lot of hard work has gone behind the scenes as far as the risk stratification calculator goes. But very, very simply, in maybe exactly 2 minutes, you can exactly stratify what kind of risk your patient has. This is a huge difference from the past risk calculator because new data, as I said, sir, has been a driving force of all research. And now we have new data which shows that how microvascular complications, how something like neuropathy, cognitive function can actually influence your management of patients during diabetes. For example, if you notice over here, you would find a person with advanced nephropathy, EGFR less than 30 at a very high risk, and a person with impaired cognition and advanced frailty at a very, very high risk. And what this risk score really translates into, when you add all these numbers, friends, you would be able to categorize whether this patient is at a low risk if the number is between 0 to 3. If it is between 3.5 to 6, a moderate risk, and more than 6, a high risk. And people who are at a low risk should be able to fast safely. At a moderate risk, you would advise them not to fast, but with proper monitoring, with maybe readjustment of medication, with the ability to be able to have social support, or there may be so many other factors which possibly you could help them fast with moderate risk. High risk patients, definitely advise them not to fast. It is not safe for them. And most of my patients, I would say almost at this point of time, very, very confidently, 100% of my patients who are in the high risk category, when you have that conversation as to why you do not want them to fast, and when you categorize it much better, saying that, look, you're at a very high risk, it could potentially be dangerous for you, and it is not required that you fast if it is dangerous for you. People often abstain from fasting. Of course, there would be some people who would still insist, and then you can take an individual decision as to how best you would manage those patients. So this is how you would look after your patients. And once you've risk stratified your patients, as I said, you would find the final risk score and decide what the risk is. So you've done the very important part of the evaluation. You've done the risk stratification. Now, in case you do not have sufficient time, there are 2-3 very important things which you need to tell your patient. A, you would need to tell them when to break the fast. Keep that as, in case you have a time constraint in your clinic, which happens in our clinics, we are all overburdened, keep a priority list. Okay, I need to definitely tell my person this is dangerous. I need to tell the person when to break the fast. Very important. I need to adjust the medication. The fluid advice, the dietary advice, the exercise advice can be given by your nutritionist. Before you actually start looking after a patient during Ramadan, have that important meeting with the nutritionist as to what exact information you want to give. If you do not have a nutritionist and you're using those printed papers, which a number of us use, explain to the person who's helping you out with the diet, it could be somebody in the person helping you out in the staff, that what food and nutrition advice you want to give your patient at that point of time. If you have the time, definitely do everything. But I know how we work in the Indian subcontinent. I know most of us work very, very long hours. So what I really want everybody to definitely do is quantify the risk, tell the patient when to break the fast and how to monitor the blood glucose levels. That goes practically in the same segment, and adjust the medications. Exercise, fluid diet advice, request your staff to give. If you give it, that is absolutely great. If you can't, then please request your staff. Keep it simple. Don't make it very complicated. I tell all my people during Ramadan, keep your water intake bottles separate. Please do not confuse it. Keep your bottles separate so you know exactly how much water you are taking, how much fluid you are taking. And when you are considering this fluid, include all those high calorie fluids that you have taken. We are increasingly requesting our patients, if possible, to stop colas completely, stop frizzy drinks completely, stop adding all kinds of, all those ruafzas to the milk, etc., and trying to just stop those additional things which are added to the liquids. We're just trying very, very simple things. Please understand it's a lifetime of consuming those. I mean, there's something called as a jaggery based, liquid which is consumed increasingly in, at least in Maharashtra. And it is a lifetime thing. Now, when you tell the person not to have it at all, they feel they're being deprived. So what we are increasingly telling our patients, have only 1/4. Keep your glass, measuring glass, and have only 1/4 glass of it. When you change meal plans, check what the person is having individually. You cannot tell a person to completely change their meal plans because that is not practically possible. But what we are increasingly telling our people, for example, definitely change from bakery products to maybe wheat-based, maybe jawara, bajra-based rotis. Now, what happens in this often is try to understand the person who's cooking is getting up very early in the morning. So we are also telling them to cook in the night and store it and then use it in the morning. So small tips like this help patients actually stick to dietary requirements. We are increasingly telling them that, of course, break your fast with a date. And what we have also realized is that if you just change the pattern of eating, believe me, people do not have salad when they are breaking their fast, at least in the Indian subcontinent. But we are telling them start using the air fryer. We are telling them that opt first for eat fruits like maybe papaya, eat apple, eat the fruits which are allowed high fiber fruits. Have your glass of milk or have your glass of sugar-free lassi. Pray and then eat your fried foods. The satiety center gets kicked in once they have taken that break of praying and then plan to eat their fried food. And we have realized that then they tend to eat a little less fried in our country at least. And that's how we are trying to manage their feasting part of the situation. And that, again, as I said, friends, is going to take some time. Physical activity continues the same, but in the non-fasting hours. So request everybody who hits the gym, who is exercise, who's also going to pray Taraweeh, that yes, you can do it you can continue exercising in the non-fasting hours, but again, be very, very particular about your fluid intake. Very important to ask everybody a very important question. Do you have a glucometer? Are you going to be monitoring your sugars with the glucometer or with the sensor? A number of our patients do use the sensor, but it is still expensive to use the sensor in our country because, as I said, we are not covered by insurance. So we still use a lot of recordings by glucometer. And the most important time, I tell my patients, especially, I try to adjust it in such a way. I tell everybody you have to monitor for the first 7 days. That is mandatory. It's non-negotiable. If cost is an issue, we tell them, please monitor your sugars at least before you break your fast, at least 1 hour within breaking the fast, before you break your fast, and at least 2 hours after you break your fast. So it gives you some idea as to what kind of surge you are seeing as far as the sugars are concerned, and are we seeing any increased risk of hypoglycemia. I also tell them that as Ramadan progresses, maybe do it around the 15th to 20th day and do it in the end of the Ramadan days so that we know that you are not facing any problem. Along with this, we tell them, please, please, please check your sugars anytime you feel your sugars are going low, even if it is 5 minutes before breaking the fast. Do not assume that, oh, my hypo is going to disappear just because I'm going to break my fast in 5 minutes. High-risk individuals, the monitoring is very different. You may decide to monitor when they get up. You may decide to monitor after they eat their suhoor. You may decide to monitor in the midday. You may decide to monitor at iftar time. These are then very individual decisions you would take depending upon what kind of regimen the patient is on, what kind of risk the patient is taking as far as fasting is concerned, and what kind of monitoring you would need. These are individual decisions, friend, and this is how you would look after your patients who are fasting. Now, what about medication? The last 2 or 3 slides about how would you adjust medication. Now, when you look at medication adjustment, we are actually, at a point of time where it's fantastic. The medication we have available to us is a very low risk of hypoglycemia. So practically you can continue metformin, you can continue SGLT2 inhibitors, DPP4 inhibitors, GLP-1 receptor agonists, acarbose or pioglitazone with this low risk of hypoglycemia, not really requiring a change in the total daily dose. You may just require change in the timing of the doses. For example, SGLT2 inhibitors, we all know, we tell the person to switch to the evening timing, that is, do not take it in suhoor and take it after iftar. Fluid hydration remains very, very important, and we do reiterate that knowledge to all our patients. GLP-1 receptor agonist, if you're on oral semaglutide, you would take it before you break your fast. You would take it with minimal amount of water, the way you are taking in non-fasting hours, and you would then subsequently after 30 minutes eat to continue. You would eat after 30 minutes after you've taken semaglutide, but you can break your fast with the tablet and a little water. When you look at, practically for acarbose and pioglitazone, you do not need any kind of adjustment. But I use acarbose a lot during the feasting time. For example, I have realized that especially if the people are going for iftar parties and are going to do a lot of feasting, that helps. But the downside, as we all know about acarbose, it does cause a lot of gaseous distension. And that kind of gaseous distension can also interfere with your prayers. And that's the reason why it's a little fine tuning you would have to do when you decide whether you want to give acarbose specifically during Ramadan or if you're initiating it only for that time. So make a little individualized decision regarding that, friends. Of course, metformin and DPP4 inhibitor, you would just continue the way you're taking them if they're taking it twice a day. GLP-1 receptor agonist injectable really do not require any change, but I do not initiate it very near Ramadan because I'm a little, and I don't up-titrate the dose just before Ramadan because I'm a little worried about the side effect profile, and I really do not want any kind of nausea, vomiting, or any kind of issue which can potentially not allow the person to fast. Now coming to SUs, friends, we do use a lot of SUs. We continue using SUs. And these are good drugs to be used in managing our patients with diabetes. I do use a lot of SUs, especially we use only second generation SUs, where we know the risk of hypoglycemia is low to moderate, but it is there. We did the Dar Ramadan study. We did the Dar Ramadan study in which we did show that when our patients, especially when they're on gliclazide once a day, you can just switch the dose. And if the people do take their suhoor meal at the proper time, for example, they are not omitting the suhoor meal completely, or they're not just taking a night meal and going to sleep, the risk of hypoglycemia is practically absolutely minimal in people who are taking long-acting gliclazide. When you look at glimepiride, again, it's the same. If your patient is taking a single dose of glimepiride, you would shift the dose to evening. If the patient is taking twice daily, but if the patient is on target, for example, if the patient's glucose levels are within the target, I would most probably reduce it to half, stop the morning dose completely. If the patient is not at target, for example, the patient's HbA1c is 8+, and the person is planning to fast, and the person is on an SU, is on a modern SU, gliclazide or glimepiride, I would keep the evening dose, and the morning dose I would reduce by half. But as I said, I would tell them to monitor themselves very closely especially for the first 1 week when they start fasting, because I would be worried about hypoglycemia before they break the fast. People do behave a little differently. The other option is you knock off the SU completely in the morning, keep the SU only in the evening, check pre-Ramadan sugars for the first 3-4 days. If they start rising, you can always start an SU in the morning at a half dose also if required. So there are two ways of working it out. You either start with half dose and see what's happening in the first 1 or 2 days, or you just knock it off in the morning time and see what happens in the first 1 or 2 days, or maybe in the first 3 to 5 days, and decide what to do accordingly. Basal insulin, you really don't need to change the timing at all, as we all know. You just continue taking the basal insulin at the same time. Most of us give it in the night, so that doesn't really interfere at all. Definitely, if the patient, you reduce the dose of basal insulin, but by 25 to 30%. In some people, again, make individual decisions. If the person is very well controlled, if this person is not going to have a proper soothe, which some people do not have, then maybe you can think in terms of reducing the dose still further. Prandial insulin can be readjusted according to the calorie content of the meal. A number of our patients do know carb counting, and these people then can readjust the insulin dose according to the meal depending upon the postprandial glucose levels. You need to match the insulin as much as you can possibly to the carb. Definitely in the morning time, but reduce the dose of insulin by 35 to 50%. We tend to reduce it and then increase it a little over the next 3 to 5 days, rather than keeping it high and running that risk of hypoglycemia. Again, in our country, we use a lot of pre-mixed insulins, a lot of pre-mixed insulins. And because we use a lot of pre-mixed insulins, what we need to understand, friends, at all points of time when we are using pre-mixed insulin is that if you're giving a single dose, take the normal dose at iftar. If you're giving twice daily dosing, then take the normal dose at iftar and reduce the suhoor dose by 20 to 50%. And of course, if you're taking 3 times, you would omit the afternoon dose and adjust the iftar and suhoor dose. Again, something very, very important over here, friends, is when you're using pre-mixed insulins, is that think in terms of using analog insulin during Ramadan. It can be used immediately before suhoor. Even if there's a cost constraint, you can use it for that 1 month, because it can be used immediately before suhoor. The patient doesn't have to wait when they're using conventional insulins. You can also sometimes take it immediately after iftar. You can adjust the dose on a daily basis, and since it's a pen, if the patient is even in a situation where they are, with family, with friends, it makes things much more easier for the patient. Insulin pump, as we all know, again, a paper which was spearheaded by Sir, which shows that if people on insulin pump can fast very safely. This would, I'm sure Manoj would be able to explain much better how we would manage the basal and bolus rate. But yes, you would reduce the basal rate by 20 to 40% in the last 3 to 4 hours of fasting, and of course increase the dose after iftar and adjust the bolus according to your insulin sensitivity principles. I've tried to sort of, summarize things quite quickly. I may have missed out on a few things. It's not possible for me to summarize everything in the time assigned to me, but please make individual decisions. Ramadan is a period where you can actually, manage a lot as far as management of diabetes is concerned throughout the year. You have a much more compliant patient. Definitely stratify the patient. Risk stratification, I think, is the most important part of managing your patient during Ramadan. Stratify your patient, identify the risk, do individualized management, adjust the medication, explain to the patient as to what kind of, what kind of management they need to do so that they can fast safely. And empower patients with these knowledge. When you empower them with these knowledge, these are people who are going to be able to reduce the risk of complications, not only during Ramadan, but mind you, throughout the year. And that is going to translate into a lifetime of much better glycemic control and reduce complications, both micro and macrovascular complications. And finally, a much improved quality of life. Thank you very, very much for having me here. Thank you, friends.
Thank you, Dr. Shella, for that amazing and very comprehensive, detailed discussion and talk on, the practical tips. Let's give it some more meaning with our panel discussion that ensues. I hand it over without much ado to Dr. Jyoti Dev, sir, for taking over and introducing our panelists and also, throwing all our questions at them.
Yeah, okay. Well done, Purvi. I would like to once again congratulate Purvi and the team for inviting Mohammed, because he is one of the main authors of DAR guideline, and we are very fortunate to have him in the DTech dialogue in India, educating the doctors. And thank you so much for being here.
Thank you.
I was listening to Sheila, continuously acknowledging you for mentoring her and thanking you for the 2026 the new risk score. So thank you and congratulations to
Thank
Dr.
you very much. Thank you.
I agree with you, Jyoti sir, and
Yeah.
I am thankful as well. Sir has been my teacher as well and my mentor as well.
Oh,
So, salutations to him and a big thank you
Thank you
to
very much.
uh,
Thank you.
all our speakers thus far and this fantastic panel that we have today.
Yeah, thank you, Purvi. So we have the three panelists here. They are all well known to every doctor in India. So we have Cheryl Silas. She is a celebrity dietitian from India, globally known and holding multiple official positions in multiple national and international organizations. And she is also the past president of the Indian Dietetic Association. And the next is Ajoy Tiwari, a good friend of mine. And he's a well-known diabetologist and a physician from Lucknow, having a huge publications and vast experience in treating diabetes during Ramadan. And then you have a relatively young doctor, Dr. Faraz Farisha, and he had enormous experience working with the Apollo hospitals. He used to be the ex-director and was a pioneer in developing the Apollo sugar clinics based out of Hyderabad. And again, with huge experience with diabetes and Ramadan. So let me start with Cheryl, because all of us were discussing about nutrition. Dr. Muhammad and also the other speakers, they were also discussing in detail about the food before, after fasting, what can be given, what cannot be given. So one question to Cheryl, and these are the questions that you are receiving from the audience. And this is about preventing the glucose spikes when you break the fast, and what are the traditional foods that you are recommending? And another very specific question, can dates be given safely in people with diabetes?
Thank you, sir, for that question. It's wonderful being here and listening to all the lectures. A lot of learnings, and thank you, Dr. Purvi, for the kind invitation. And I think this is very relevant because we do see a lot of people, and initially we used to tell them that if you have diabetes, you cannot fast. But now with technology and so much of recent research and evidence that we now know that we can safely fast during Ramadan. But very important is, like we were discussing, it shouldn't be fasting and then feasting, which usually happens. So the whole purpose of Ramadan is sacrificing one meal for the poor. And it requires a lot of self-discipline. And, so very important is the iftar. So when they're breaking the fast, dates is something that they break their fast with. Of course, we allow them to have dates, but we tell them to have one or two small dates. If it's the medjool dates, they're slightly bigger, more sweeter. So then maybe half of it, and then have water. So very important is to break the fast with water. And like Dr. Shella said, then say a prayer and then eat a meal which has got a good combination of carbohydrate, protein, and healthy fats, and of course fiber. Again, we tell them because in our part of the country also it's going to be summer, so there's risk of dehydration, and a lot of water containing fruits and vegetables are available. So we actually tell them to consume water containing fruits and vegetables, which is again, traditionally consumed. So they would have either papaya, musk melon, or watermelon, then cucumber, celery. So those kind of fruits and vegetables. And because everybody is making, so there's a lot of fried stuff that is made and a lot of unhealthy stuff that is made. And they will have roux afzas, which is like a lot of sugar sweetened beverages. We would tell them to choose healthier beverages. And I think very important is counseling the entire family, because only then can we achieve that kind of what you say adherence. So we counsel the family together and tell them all to be a part of it, and they do enjoy it. So we tell them, instead of taking those sugar sweetened beverages and roux afzas, you can actually, like Dr. Shella said, either tell them to have lesser amount with lesser amount of sugar, or we tell them to take buttermilk, or the salted lassi, or unsweetened lemon juice. We can ask them to put some chia seeds, mint, lemon to it. And definitely water is another thing that we would ask them to hydrate themselves with. And when it comes to nowadays, you have air fryers, we tell them that instead of frying or deep frying, try and use, have these chicken tikka, paneer tikka, or fish tikka, which is not having too much of oil. And of course, keeping the salt content less, because that will further add to more dehydration, because, and also that, especially in the morning time, if they have more salted foods, they feel more thirsty. And then making a good combination of, so basically a lot of refined food gets consumed at that time. We tell them to use more complex carbohydrates. You can make a broken wheat pulao, or you can use different kinds of millets and grains, of course adding a lot of vegetables and fiber, or just your regular food. And then there is the Taraweeh prayer, which also is a prayer where people, there is a lot of calories that is expended there. And then in the night, we tell them don't eat too late in the night, because if you see, especially the streets of Mumbai, there's sometimes no place even to drive, because everybody's on the road eating till around 2 and 3 in the morning. So there's a lot of feasting that happens. So we tell them to, end the night maybe with a cup of milk with some nuts, because that will keep them sustained through the night, and also keep their blood sugars levels sustained without causing those sharp peaks in blood glucose levels. So definitely the thing is to use more complex carbs, protein, healthy fat, fiber, more water containing fruits, one or two small dates, or if it's a medjool date, then half, maximum maybe one. And then making sure they have unsweetened beverages, and again using, different techniques to keep the low oil less. So maybe steamed, or maybe just grilled kind of a chicken or fish. That would be more a healthier option to have.
Yeah, it has been very extensive and simple. So thank you, Cheryl. I will come back to you again. So now it is Dr. Ajoy's turn. So we have been discussing about the new Ramadan Risk Score 2026. And you know that it has always been challenging discussing with our patients. And that is one of the reasons why we are again here as a team. And we discussed on collaborative approach, the shared decision making. And every year Ramadan is happening, but every year we will have similar meetings, because it is still a challenging scenario for the doctors and also for our patients. So how is the new Ramadan score going to help you? And which are all the challenges you believe will be taken care of by the new score?
Okay. So I think this is a very important point, because there is a lot of religious issues involved in Ramadan fasting. So if you tell your patients that this particular risk score has been developed by the muftis and the medical fraternity together, so that is something which gives a lot of validity to these scores. So that is very important. So as it was being discussed earlier also, that it is very difficult to convince the patients whether they have to fast or not to fast. So if you give a structured program, that is, this is Diabetes and Ramadan Alliance, a structured questionnaire that gives a very nice start to risk stratify these patients. Because what I think that if you stratify the patients properly, and we have already produced a lot of abstracts on that, which has been presented, the education part is very important, the initially, and the risk stratification, if you do early on, that will help a lot. And if you compare the 2021 DAR Alliance risk score and the current one, 2026, so it has been, Dr. Hasnin is already here. And I find that it is really a very nice piece of work, and a lot of technology has also been brought into it. And the best part I found was that if you're using a CGM, you get a minus 0.5. So that's something which is very exciting. And secondly, what I find very interesting in this particular risk score 2026 is that they have categorized that pregnancy is a definite risk. So earlier they were using that if you have a controlled sugar levels, you have a score of 3.5. So that could convince some of pregnant females to fast. And I think pregnancy is a state where you should not fast for sure. And it is also mandated by the religion also, that is a definite no for fasting. So all these good things have been accommodated, and a lot of technology has come. So I congratulate Professor Hastin for this wonderful score. And we are using at our place for risk stratification of all our patients who need to fast, or we are asking them proactively, because they don't come forward. What is the biggest problem is that in India, they don't come forward. That we ask them proactively, do you intend to fast? because you have to ask this question. Otherwise, what they will do, they will adjust their medications on their own and they will try doing the things on their own. So always ask them proactively, and all Muslim patients have to be addressed about fasting. So that is very important.
Yeah, well said. I think these are all practical tips, and these are all challenges that we are facing in our day-to-day practice for many, many years, because I have been discussing with our patients for almost close to 3 decades, and every year it is a challenge. And it has to be customized, and there are people who have chronic kidney disease, advanced kidney disease, recurrent episodes of hypoglycemia, but they'll be very adamant that they should be fasting during Ramadan, and the guidelines are actually helping us a lot. So I say that this is developed by the International Diabetes Federation. I will show the pictures of doctors. I have shown the picture of Dr. Muhammad multiple times to my patients, that this is a world famous person, and many people are involved in this, and the Egyptian doctors are involved, the priests are involved. So then only they will get convinced. And this is working for more than 90% of our patients, 90%. But still, there are challenges. And my question to Dr. Faraz, if a person is fasting, and whatever be the risk involved, it can be low risk or moderate risk or severe risk, when should they stop fasting? So what advices you will give for that? So the scenario is that they are not using any technologies, because we know that not even 1% of our patients are using technologies such as continuous glucose monitoring, though it is there. So that is a real scenario. Yeah, please, Faraz.
Yeah, thank you for getting out that. I think that is again a very practical question when it comes to management of patients with diabetes. So I think most of the time what we see is the two spectrums, of course. So they are at risk of hypoglycemias, or they are at risk of developing hyperglycemias. Summer, I think dehydration is one another thing. And then some certain times, if we are not doing the disease modification or the drugs, if we are not modifying it, patient is on SGL2. I think we've seen patients landing with euglycemic ketoacidosis as well, because many of the patients, just as Dr. Ajay was saying, continue to take the drugs without the advice of the doctors. So I think what we generally, and what Dr. Ajay was saying is, I will continue from my senior colleague, that what we do is at our centers, of course, now more than 13 years we've been doing that. So, but then every year, 6 weeks before, our team starts putting a group mass campaign to all the patients, saying that same thing. If you are trying to fast, come back to us so that we do the risk stratification. And certain red flags, I would say, we tell them that you do monitoring of blood glucose with your glucometer. I think that is the simple and the best way they can monitor it. So if the sugars are going less than 70, we tell them that that's a red flag. You have to break your fast. If it is going anywhere more than 300, then they have to be again, calling back the doctor and asking them if they are developing symptoms as well. So certain, we are telling them that if they feel lethargy, if they're getting sweating, so if symptomatic hypoglycemia is also there, and if they do not have a glucometer, sometimes still, I think you will also agree that most of our patients have it, but some of our patients still do not have the glucometer. So symptomatic hypoglycemia, if they develop it, so that is again one indication where we are telling them that, oh, it is very important that you go ahead and break it, even if you're not seeing or you're not documenting it. But if you're developing a symptoms, then you have to go ahead and break it. And then hydration. I think another most important part is going to be the hydration, which is very, very important. And it has to be done at Seher and at Iftar as well. So that is few of the practical guidelines, leaving all the dark, beautiful guidelines of what we have. These are some practical tips we are telling our patients, that these are the red flags and they need to follow that.
Okay, fantastic. Dr. Mohammed, I have a question to you, and this is based on the discussion that we have on technologies with the use of technologies in diabetes. So, I'm sorry. So the technologies have actually helped in modifying the guidelines, and even in 2026 guidelines, we have been discussing about the use of continuous glucose monitoring, and where you have minus 0.5. But what is the status of type 1 diabetes? Because type 1 diabetes means that it's at high risk. And not even 0.5% of these people with type 1 diabetes globally, even in the high income countries, they are not regularly using the continuous glucose monitor. Very few are on automated insulin delivery devices. So what is the general advice which can be given, or it need to be again customized? And I have a question on the score which is given against the type 1 diabetes. Don't you think that ideally it should be 6 or even more?
Okay, perfect.
Yeah.
I wish I can share and show you live, but let's do it without being live. So the technology in the last guidelines have looked into not just the CGM, but the insulin pumps as well. If you look into the older version, it would put insulin pumps at the same level of basal bolus insulin. But now we have the insulin pump, the automated pump, lower than the basal bolus, and the closed loop and the open loop at a slightly different level, because obviously based on the evidence from the studies that were done by Nancy Barberry, by Mohammed Sulaimani from Riyadh, and by others. So the technology, not just in the CGM, but also in the insulin delivery. Now, we give an extra point for type 1, regardless of, then you will not just type 1 give them 1, because they will be on either basal bolus or intensive mixed insulin or a type of pump, and that will score. The frequency of hypos is a bit more than maybe someone on metformin, so that will score. So finally, the score of a person with type 1 is much higher than a score of a well-controlled. So the best controlled type 1 will score higher than the best controlled type 2 on oral therapy. But with the use of technology, and if someone is having the rare hypos and very good control and don't have other problems, they could be at the lower end of the score. And this is a recognition of the fantastic technology that's been having. We have patients nowadays who, in all honesty, on these closed loop pumps, and they come with a control better than some people with type 2 diabetes not on insulin, maybe even on sulfonylurea. So we had to recognize this. And the work is ongoing to further modify this in the future. So the technology aspects are part of the major information here, whether it's the technology in the type of therapy or in the delivery of insulin or in the glucose monitoring.
Yeah, I think Dr. Benshi is also there. I don't know whether he's listening or not. If he's there, Benshi Sabu, because he's having a very special interest in type 1 diabetes. More than 100,000 people are there in India with type 1 diabetes. Considering the fact that most of them are only on glucose monitoring with a glucose meter and on basal bolus insulin, or sometimes only on a premix insulin, now very rare. A general statement to be given for type 1 diabetes with respect to fasting during Ramadan should be?
I don't think we can generalize because even it's not just about the therapy. So, or even having the facility to monitor. How well is your control? How frequent are your hypos? What's the nature of your job? Are you exposed to hot weather and intense physical activity or not? Do you have other complications or not? So in general, if you want to generalize, people with type 1 diabetes will score higher. Okay, they are likely to be in the moderate or the high risk, but it will really vary a lot. I'm trying to, as we speak, to do the score for the best ever type 1 person. Give me a second.
Absolutely.
Yes, health education, yes. Show the result.
Cheryl, I remember you have written a book on carb counting and insulin pumps. And that was published when insulin pumps were launched in India way back in 2005 or so. So do you have any books on Ramadan fasting and nutrition? So we will listen to Muhammad and then get back.
Okay,
Yeah.
sure.
So the best controlled person with insulin pump, the automated pump with good control and with very infrequent hypos, as frequently they are, and not doing an intense physical job with no complications, that person will come as a low risk. And we have some of these patients coming to clinic. I'm sure you have patients on pumps, if I remember right. So how frequent do they get hypos?
Yeah, with the new 780Gs and automated insulin delivery, hypos are almost completely eliminated. It is only
Exactly.
it's only hyper.
And with the right education, and as Cheryl mentioned about avoiding the spikes when they eat, and even though the pump will be able to overcome, but sometimes it's a bit delayed, and if their glycemic control is good, then the score will be in the low range. Yes, of course, this is the tiny minority of people with type 1 diabetes globally, but we shouldn't really deny the fact that they are possible and they are there. Basal bolus patient, if they are well controlled, checking frequently with SMBG, they will also be possibly on the lower end. They're likely to still have some hypos, but you can get a type 1 diabetes now with the best control on the closed loop pump on the low, or a very well controlled person on the moderate risk level. And moderate risk is 50-50. They have the right to fast or not to fast, and certainly many of them are able. When we saw the data, we found that about 60% of people with type 1 diabetes were fasting the full 30 days. But obviously, now we should not forget that a third of them have already decided not to fast at all. So the first filter is those who decided not to fast. And obviously, if we apply the filter more and more, there will be more of the people who rightly should not fast. And some of others who are rightly will be able to fast and enjoy the month as much as others.
Do you have any recommendation of the age limit in type 1 diabetes? Those who can safely fast and cannot.
Age-wise, you mean as young or as old?
Yeah, in pediatric age group, in above the age of 15 years, above the age of 18 years.
Sure. The official line is fasting is obligation for an adult. So kind of puberty time.
Yeah.
But obviously we see many teenagers in their 13s and 14s who their mates at school want to fast and they feel maybe inferior. In the past, we used to be emotional and say, you're quite young, you shouldn't fast. But actually, when we compared the data, we did one study below 18 and above 18. They are likely to have shorter duration of diabetes. They don't have complications. So it's just kind of an emotional protection as parents that you're quite young, you shouldn't fast. I'm not saying at all that they should fast. But what I'm saying is they are likely to be fitter and with less complications. So if they are well controlled and able to match their insulin with what they do and what they eat, they probably wouldn't have a problem. But again, the official obligation is when they are adults. And adults is not a government decision of you're 21 years old or 18 years old, is puberty wise, kind of like you've reached adulthood.
Lot of valid points. Thank you very much. Thank you very much, Cheryl. A few more questions. What are the 3 most important nutrition tips for a person with diabetes during Ramadan?
The first thing is not to miss the suhoor, because typically what happens is if they're eating very late and very high fat food and they can't wake up in the morning, they usually end up skipping suhoor. They don't even drink water. So that can put them at a risk of dehydration and even hypoglycemia. So basically have the suhoor meal and also have it as late as possible. That's the first thing. Make sure that it's a good combination of complex carbs, protein and fat. Like Dr. Shaila said, it's very difficult in the morning for somebody to cook a meal. So something which is simple to make, either do the pre-preps earlier in the night or maybe an egg wrap or a paneer wrap milk, some fruit and nuts would be an ideal thing. And nothing which is very high on salt, because then that can lead to dehydration. And same thing, nothing very rich in caffeine. So that's the first thing. Second is iftar should be a meal of moderation and not indulgence. So again, starting with maybe one or two small dates, and then water, very important, and then water containing fruits and vegetables, maybe chana chaat or something. And again, making sure that it's not going too late in the night and not high fat, sugary, salt foods. So definitely not the sugar sweetened beverages and high fat foods. And again, very important is, the physical activity component as well needs to be managed well, and a good balanced meal. It shouldn't be just one thing that we're focusing on, because of course we have to meet our nutritional requirements, making sure that there are no peaks and troughs, so no hypoglycemias and versus hyperglycemias. And if somebody is on insulin, then matching the carbs to the insulin to make sure that there is no hypoglycemia that happens because of the insulin, or maybe even certain drugs which can cause hypoglycemic risk. So these are important things that we need to basically educate. And always, I think even when we know that the person is wanting to fast, they have to basically come to us at least a month before, or a few weeks before at least, so that we can counsel them, make sure that their glucose is under control. And most importantly is doing and counseling the entire family, so that everybody does it together, so that the person with diabetes does not feel deprived or being one-sided thing. So it should be done by as a family thing, is what we would
Yeah,
encourage them.
yeah, I completely agree, because before the fasting starts, we should give advices to the patients, and
Right.
most of them will approach us. So I have a common question to Ajoy and Faraz, and Ajoy can answer first. And this is on how you manage before Ramadan, because we have to customize the advices, and we have patients on insulin, we have patients only on oral agents, we have multiple patients, thousands of them are having uncontrolled diabetes, we have type 1, type 2. So how you give them advices? Is it in a webinar, or is it in a one-to-one program, or will you invite them, all of them, for a big program, and we'll have a group discussion? So how practically you are doing it on a year-to-year basis, so that the message is conveyed, all the aspects that we have discussed here, preventing a hyperglycemia, preventing a ketosis, and how to fast without developing any complications. So this requires at least 1 or 2 hours of education. So how are you practically managing in your hospitals?
Okay.
Ajay.
First thing is that you have to have multiple platforms to reach out to the people. So firstly, what you do at your centers, so 4 weeks prior to Ramadan, we start our structured education program. And as per the guidelines, what are available with us as regards to IDFDR, we try to educate the patients beforehand. Risk stratify them, and also tell them some of the patients do fast in the month of Shaban, that is. So we also tell them that you can also change the medications, what we are prescribing them, how to adjust the medications prior to Ramadan, so they can have a test run also. So that is how we do at our place. Social media is a big platform, so we organize social media programs. So I've already recorded a message for our patients and to reach out to the people. Then third place is mosques. That is very important. So during Friday prayers, we just a small piece of paper writing the important things. So that could be a very good idea to reach out to people. So we always do it through our charitable organization. We put an insert and send it to the mufti of the mosque, that you can share with your people who are coming for Friday prayers. So that is a big place for congregations, and we can reach out to people. Then we also organize press conferences prior to Ramadan every year. We have programs for primary physicians, those doctors, the BUMS and BAMS doctors, who are the primary people who will be seeing the cases of hypoglycemia for referral and all that. And then we are also having structured programs under RSSDI. So that is a program for our colleagues of RSSDI. So these all things are planned prior to the start of Ramadan. So this is how we reach out to the people.
Good, good. And what about Dr. Faraz?
I think we all are working on something similar guidelines, but what we are doing is, so we every year what we are doing is we are identifying that high risk population, especially the geriatric elderly population, who wants to fast, but they are at that moderate and a little more risk. So what we do is we get a database because we now have the EHRs. So what our dietitian does is 6 to 8 weeks before, she starts having a one-to-one webinar session. So we have like 100 patients joining in that webinar. So she starts counseling them on the diet aspect, the hydration, the physical activity, and all. And then in these patients who had a hypoglycemia risk last time, so we tell them that you come and meet the doctor, so that once they meet us, we are able to adjust the medications and then reassess why did that hypoglycemic event happen last year. And then we are also using the EHRs because there's a huge data of patients which are there to give them a small message. So what we do is right from 30 days before the Ramzan, every day there is a snippet which is going on as two messages. One message goes from the physician, so from the doctor side, and one is a dietary tip. So one goes in the morning and one goes in the evening. So 30 days before we start giving them, and during the period of Ramzan also, we give them. So it goes to like 18K, 20K, 25K patients in every day. So we use that EHRs so that they every day you give them a small message, say just keep hydration maintained. A small message so that fits them properly, and so that it helps them in a longer way.
I think all of us are doing it every year. But apart from the religious fasting in the Islamic population, there is fasting in the Hindu population, there is a Christian population. So the religious fasting is there for everyone. So how do you manage Ajoy? This question is to Ajoy with respect to the fasting in Hindus, in Christians, in Jain population. Do you manage in a similar way, Dr. Ajoy?
Technically, the Hindu fasting and Jain fastings, they differ in that way because most of the fastings they do not are of very long duration. Firstly, and secondly, we are allowed to have some amount of things like fruits, falahar, and water is allowed during these fasts. So obviously, we always try to educate them, and few fasts are like that. Some are nirjala vrats. Nirjala vrats are that when you don't take even water also, but they are for a single day duration. So simple message is that when you take your food, you take your medication, and when not taking your food, you don't take your medication because it's for a very short time. So that is how we approach them. And secondly, it's a very good learning experience also because you are trying to avoid carbohydrates during those periods. So that could be a good message to them and a good learning experience for them that yes, if you see and if you see your CGMs or you see your blood sugar monitorings, you will see a better glycemic control during those periods. So it could be a good experience. So obviously we have to be very careful during all fasts. And what I intend to actively ask them every time, be it a Karwa Chauth, be it a Nirjala Vrat, we have to ask them proactively, are you going to do it? Because they will not tell you about that. So that is very important.
So I just want to add here, I think it is a quality of nutrients because that is usually compromised in fast, because it's all very simple carbs, very high GI carbs. And of course, because after a fasting period you're eating, then you end up eating a lot of food. So I think that is something that we need to emphasize. And even in our clinic, we actually give them recipes. So for suhoor, what they can prepare, what is easy to make, and then even for iftar, that becomes very handy for them, which they can, adopt as an entire family and as a community by itself. Yeah.
Super. Dr. Muhammad, I have a question to you. Many times
before that, if you just allow 30 seconds. Sorry. So, sorry, Mohammed, between I am interrupting. This is what I do in my clinic. And I think under Diabetes India or IDF or by RSSJ, detail, it should be a part of checklist. Like each and every patient who is coming to your clinic, we must ask him, are you going to fast or do you fast of any religion? So this will be also entered in your EMR system. If someone is saying that, yes, I regularly do Ramadan. If your patient is saying I do Igyaras every month. If your patient is saying on every Tuesday I fast. what type of fasting which you do, whether it is a Jain or whether it's a Hindu or whether it's of any community, you will understand as a part of medical history. Unless we teach this thing to 40,000 physicians who are practicing diabetes in India, we will not able to take care of fasting. These few experts who are meeting and seeing and learning about how to take care of during fasting, you don't know how many of them are doing it. So it should be a part of your checklist program. Like, you are checking it for a clinical examination. In a diabetic patient, this is very important. And then you are dividing your therapy in two parts. You can say very confidently, yes, you can fast because you are in low risk. You are using a molecules which are already diabetes, molecule which is not going to cause hypoglycemia. You are not worried. So you can say, patient, you are fit for fasting. You can write down like that. This I do. If your patient is already at high risk, geriatric, he is maybe in a position go in dehydration, or he may go in severe hypoglycemia, or he is a person who is in past had already developed some problems. You give instruction at that point of time. Don't wait for till Ramadan to come. Don't wait for his next fasting plan. And then you tell that whenever you plan to fast, these are the ways which is how you have to fast. This is the what you have to do. So this we have to teach, just not a teaching on one particular day, just pre-Ramadan, and we are teaching everyone that how Ramadan fasting to be done before 8 days, or in next 2 months later on, we are just forgetting that how fasting to be done. It's a throughout the year, 24/7, each and every patient. If I have today seen 60 patients, in each and every patient I have written whether are you going to fast or not. This should be part of your, in a, the diary which I give to the patient or the file which I am giving the patient. Like we examine the food for tick box. Have you examined the food? My assistant, yes, we have examined. Is it at high risk? No, it is low risk. Is it at any problem? Peripheral neuropathy? No. The same way fundus is examined in this year. Is it dental examination is done or not? In the same way, in a checklist, the fasting should be asked by the clinician. And that should be done at every level. Either a person is seen at a primary care physician or someone who is sitting at a tertiary care level at a professor or endocrinologist. That's very, very important. So, I mean, that's the reason, Mohammed, I asked
I concur with what Banshi is saying, because if just 2 weeks after Ramadan is over, I go to one of you as my doctor, and you decide to put me on a drug which is less Ramadan or less fasting friendly. Let's forget the word, the type of fasting, less fasting friendly, and you had an option. So then we need to preempt the problem from the very beginning, knowing that I do practice fasting that contains some sort of food restriction or calorie restriction or even fluid restriction. Then I need to be conscious about this to make the right choices from the very beginning. That will help people, specifically when we used to advise review your patients 2 to 3 months before Ramadan. I work in a Muslim majority country, so I cannot review all my patients 2 to 3 months before Ramadan. That becomes a massive workload. It's much easier when I was working in UK, when you have, for example, 5% of your patients who are fasting, and we used to have specific clinics for them on a Saturday morning or whatever. So as Banshi is saying, it's a point that we need to think of. It could be intermittent fasting, which is the same process for diabetes from diabetes point of view as not too far from Ramadan fasting. So it's really quite important that we utilize this. And the other crucial point is converting religious fasting into healthy fasting. With religious fasting, you do the obligation for your God. But then at the time of eating, you might overindulge. But healthy fasting is the opposite. You do it for yourself and you are conscious of what you eat. If we can merge, because in the past, the religion wasn't saying to us, have a feast every day. It defeats the objective of the fast. It's meant to feel for the poor rather than I'm having a feast every night and continuous. Some of the guys go to restaurants and hotels where it's an open buffet until dawn time.
It is there.
That's not the essence of Ramadan or any other religious type of fasting.
Even rather, we are also invited for all those iftar.
But I mean, Banshi has mentioned also one point that we are about to take part on, We are about to take a survey similar to what we've done in Ramadan for Christian fasting, Orthodox Christian fasting, because some of them fast 200 days plus a year.
Yes.
Different types of fasting. And we will, Banshi is part of the fasting committee with us, and we're going to try and find out how many people in different countries are fasting and what type of fasting and what impact it has on their diabetes. So we have lots of data now on Ramadan fasting, but we have very little data on other types of fasting. And instead of just giving a consensus opinion, it would be nice to start the ball rolling for evidence-based fasting practice.
Mohammed, there is one more problem in India. Even Hindu fasting in different parts of the country is also very different.
Yeah, sure.
Like in UP, Rajasthan, that's north part of India and south part of India. The same Hindu religion will do fast in a different way.
But we need to understand what do they do. So it's exactly like Christian fasting. When I was in UK, my colleagues would say, when I fast, I give up chocolate. That's nothing to do. That's good for diabetes. But the
Jew also have the one fasting. I don't know what variety of fasting. But in India, we have two very unique, one with Hindu and other is Jain. And Jain are very, very particular in their fasting. So they do, like you have said, that alternate day fasting, which is very difficult throughout the year, 365 days. I have in Gujarat and Rajasthan very high number of Jain, and they do alternate day fasting. It is for 365 days. And then to their manage the sugar is really difficult. Every alternate day, they will eat. One day they will completely fast. Again, one day that. Then there are 1 month fast. There are fast only for Chopasa, that is 3-month fast. So these are the different type of fasting which we have. But Jain have more, rigid fasting in compared to Hindu, as you had said very rightly, that they eat also once in a day. So there to manage is like with a short acting. That's the reason the glinites and the acarbose or regulibose, they are more commonly used in India because we use these molecules. When you fast, you don't take. When you take, you can take extra, something like that sort of thing. And we try to manage. But definitely this continuous glucose monitoring has changed the way we were treating diabetes patient with fasting. And now we are more confident in treating these people with fasting. And we can say, yes, you can do, but these many checks which you have. But still,
I'm really enjoying the discussion, but I have to admit, I've got to go to another meeting.
It's again also at 10 o'clock in India.
Yeah,
it's 10
we were meant to finish a bit earlier than this, but I've got to go in less than 3 minutes to another meeting.
Yes.
Am I
Jyoti,
being
you can
excused?
conclude, and Purvi, you can conclude.
Yeah. Thank you very much, Purvi, for this opportunity. So I hand over back to Dr. Purvi. Yeah.
I think the discussion has been beyond our expectations and very, very comprehensive. And I think it was just beautifully directed. So a very big thank you to all the DTech founders to be here today. And on behalf of them, let me thank our experts, starting from Professor Mohammad Hassanin, sir, Professor Sheila Sheikh ma'am, and also Dr. Hossam Ghazi from Egypt, and our expert panelists, Dr. Ajoy Tiwari sir, Professor Faraz Farishta, and my dear friend Cheryl Salis. I think everything, and Dr. Jyoti sir, you were just fabulous. I think you really stirred a very stimulating discussion. So personal thanks to you all. I think we feel like we know a lot about fasting and feasting. And then every year when we have this webinar, I think there's so much more to look into. So thank you again. And we will definitely, this is a promise to our audience, we will be arranging more webinars with more of experts talking about the diversity of India and the diverse fasting regimens that different religions and different sects observe. And we will definitely talk more about them. It's not possible to have everything in one session, but we will, from time to time, we will have those sessions as well. And we will pick your brains more on those regimens as well. So with that, thank you and Shabba Khair. Good night, everyone. And stay tuned for DTech Dialogues in the future as well.
Thank you. Bye-bye.
Yeah, thank you,
Bye-bye.
everyone.
Good night.
Bye.
Good
Good
night.
night, everyone.
Thank you, Dr. Singh. Bye. My boss, Raz, waiting for